Hi everybody and welcome to this session. I'm absolutely delighted to be here today, and I want to thank NHS Confederation and NHS England for inviting me to take part. I think there's been some great sessions today, I know that, and I've heard about all of them, including someone who won't be upstaged, which is Rob's wonderful son, George. But we're going to make this a fantastic session too. And I said to Rob earlier, if it starts to go downhill, we'll just bring George on again, because that's clearly the winning formula. Really delighted to be here and to talk about health inequalities and really about how we make this reality. We talk about the business case for it, but what does the business case mean? It means telling you why it makes sense. And I think that this is really going to be a learning session for us today. Before we go into the substance of the session, I just want to say a little bit about what NHS Providers, which is my organisation, has been doing on health inequalities. We've got a new programme launching later this summer, which is a programme of peer learning for senior leaders on how provider collaboratives can use shared improvement approaches to tackle inequalities, while also making sure that they are really making progress on key operational priorities. And then we also have an ongoing health inequalities programme, work very closely with Bola on that. Do hope you look it up. It's basically about making sense of health inequalities and helping trusts and their partners to really embed it as business as usual. And I think that's a part of what today's session is really about. This is our business. This is what we do. It's not the added extra that you might think about on the side. This is core to what we do. And I think having the speakers that we've got today, who I will introduce in a moment, I think tells us about both what's happening at a national level with Bola's work, what's happening at a system level with Rob's work, and then also what's happening on the front line with Owen's work and how they all interconnect. So I am now going to start the session. Hopefully you are all familiar with Slido, because we're going to be using Slido throughout. I'm saying that like I'm an expert at Slido. I'm really not. So if anything is a bit clunky, that's my fault. First, before we kick off, there are 2 Slido questions we would like you to answer, and we will come back to the answers for these in a moment. But the first question is, how is the Core 20+5 approach enabling your organisation to reduce health inequalities? So that's the first question we want you to answer. And then the second one, and this is a really important one, what are the barriers in your organisation to reducing health inequalities? And I think, without that, we can't really make those steps forward that we need to make. So you get answering those Slido questions, and while you do, I am delighted to show now a short film which chronicles some of Bola's visits across the country. And once we've seen that film, we will then come on to Bola's presentation. So can we cue the film, please?
Today we want to find out why you don't go for your bowel screening, why you don't go for your cervical screening, why you don't go for your breast screening, and what we can do, what the NHS here can do to make it easier for you.
So these ladies said they never even received the letters yet. This lady said, I have received the letter from NHS England, but I have never been. And I asked her, what is your reason for not going? Are you worried? Is it because you don't understand? She said, I'm not scared, I'm not worried. I just don't feel anything's wrong with me.
Tell me about MUMTA. What is MUMTA? It's a programme to support women from ethnic minority communities in pregnancy and after the baby's born. And our aims are really to improve outcomes for mum and baby.
What we're trying to do is a bit more of a national campaign around awareness of sickle cell disease, and use that as an opportunity, I guess, to kind of draw attention to both some of the really great stuff that's going on and how we can improve care, but also some of the things that still need to change.
Ever since we've been in Basildon, it's been such a seamless experience. They're making our lives easy. My daughters we shouldn't be looking forward to coming to the hospital, but I remember when she was being transfused, she loved it here.
I found it through friends.
Yeah.
So there was it's mental health and So at the time I had people doubting me, so that kind of helped me come here.
The amount of times I've come here in the morning and I'm like, oh, I don't feel too well, I'm not going to talk to anyone, I'm not going to participate, I'm just going to be quiet and just get on with it. And that never ends up happening because I usually end up becoming alive and speaking to people.
I got diagnosed when I was really young with schizophrenia. You meet some interesting people and you don't just meet one type of person because sort of mental health problems affect all sorts of people.
You can't always mend people completely. You're living with a lifelong condition, but making small changes and we're all working together as a team is very rewarding.
Everybody comes because you've got to crack jokes, be silly, be stupid, take the mickey. And everybody just goes home with a big smile on their face.
I would definitely see the NHS as one of my main jobs, not necessarily specifically here, but it does help to be here, kind of to get that initial experience.
Yes.
Yeah. So definitely in the NHS.
These are the courses you can go on to, just to upskill what you already know. It's bringing my confidence back up because my confidence was rock bottom, and I've recently lost my job, so I want to try and choose a new career in admin in the NHS.
So I was living in housing benefit supported accommodation, whereas this accommodation I didn't need the housing benefit. It took me off benefits and it enabled me to get my own job and start my own career for myself.
Without Live and Work, without St Basil's, Apprentice House and the NHS, I think it could have been very different. There's a possibility I could have been on the street, so It's a massive opportunity.
Brilliant. And I think that just gives a flavour of the immense potential of tackling health inequalities and really turning what can be some really terrible situations into massive opportunity and really fulfilled potential and life chances. So I'm now going to turn to Bola, and before I do, I'm going to introduce her properly. She is one of two professors we have on stage today. So Professor Bola Owolabe, who is the Director of Healthcare Inequalities and Improvement at NHS England. And I always love hearing Bola speak, so I'm really looking forward to this. Got about 10 minutes for your presentation. Then we'll come back to some of the Slido questions, and if you have any questions for Bola, then please do put them on the Slido too. But over to you, Bola, for your presentation.
And thank you so much, Saffron, for that very kind introduction. Well, I hope the people that you've all just met in that film have made the business case for tackling health inequalities. Everything else I'm going to be saying is to try and just embellish the powerful case they've made, I hope. You heard about the young man saying, I would have been on the streets, without the collaboration of the NHS and these organizations that he was talking about. You met Elliot, who described himself as having global developmental delay, but he was doing such an amazing job in that dispensary at Basildon and Thurrock hospitals. And I think of people like Elliot, people like the last person on that slide, those women at Sharma that I met being encouraged to go and have their cancer screening done. And really that is the business case, because if you consider the fact that actually people from our most deprived communities, they develop long-term conditions earlier. Those conditions accumulate faster. It means they live with them for a lot longer, which for many people then means earlier exit from the workforce. And you begin to see the loss in terms of the human capital. We lose the community contribution they could have made, the tax revenues they could have made, the higher healthcare expenditure that all of that then commands. You begin to see that actually the conversation about health inequalities is not just a moral or an ethical imperative. It actually costs us as a system. I've put the people cost as the first slide because I wanted to translate the voices of those people into some data. And the fact that, when we went into the pandemic, we had this huge life expectancy gaps. particularly for people living with learning disability or people with serious mental illness. You know, for people with serious mental illness, it was 15 to 20 years. That was the life expectancy gap between them and the rest of the population. And that's going into the pandemic. And I'll pull out just one data point during the pandemic. If you were from the poorest 20% of the population, then your mortality from the infection from COVID virus was double. Your mortality was double compared to those people in the top 20% most affluent. Now that's the people cost, and I hope that the conversation we will have subsequently actually addresses that. But actually, I want to leave you with a sense of hope that we are making progress. You know, I've been in this role a couple of years, and I just want to salute the people who have listened and gone away to make a difference. And I want to call out the lung cancer program, which, you know, as you know, that just 1 in 3 people who have lung cancer have it caught at an early stage. Others do tend to be later on, you know, in their journey. And if you happen to be in that poorest 20% that I was talking about just now in relation to COVID, let's think about them in relation to cancer. Then your risk of lung cancer is 2.5 times that the richest 20%. But actually, look at this. The proportion of us being able to catch lung cancer early has grown exponentially over the last few years. But I want you to notice how it's grown even more for people from our most deprived areas. It can be done. And you know, that's really the message that I want us to go into this conversation with, that yes, we do need to talk about the challenges. Yes, we do need to talk about how it's costing us from a human point of view, costing us from an economic point of view. As a matter of fact, I will go as far as saying it's financially illiterate to not address health inequalities. You've only got to look at the numbers to realize that there is a financial illiteracy to not address health inequalities as a priority. Think about these people from these poorest areas that are having their lung cancer diagnosed earlier. The fact that their outcomes are therefore more likely to be better, their lives and their outcomes for their lives as a whole better, the likelihood of being able to return to work better, the contribution that they can make to society better. So when we look at this graph, I want us to think about people and the people behind these numbers and the difference it's making in their lives. I'm delighted, I'm sure I saw Professor Kiran Patel and his team just now, just at the front. I spent some time with Coventry and Warwickshire. Again, just take a look at that graph. So when we talk about the electives waiting list and the call to restore our NHS services inclusively, and the fact that that's not a binary call, it's not either one thing or the other, it's both and. You know, we can get on top of the waiting list, and we can do so in a way that means that our most disadvantaged people are not left behind. And this one slide tells the story of both and. You know, this heart tool that they've developed, and I had the opportunity of spending a half day with them, just sitting with the different admin staff, and also our clinicians who have seen how we can look at that waiting list differently, in a way that helps us to really not only see the clinical imperative, but also the human imperative of an inclusive recovery. And I hope that this slide shows and tells a powerful story that we can focus. And when we focus, we gain traction. And with that, we can demonstrate impact within a reasonable time frame. So the business case for tackling health inequalities is not a business case of invest now and reap the dividends in 10 years. This has been achieved within 18 months to 2 years. This is a business case of a very narrow window between investment and returns, ultimately to give people an equitable access to our services, for them to have an excellent experience of us and the care that we give, for them to have the optimal outcomes for which we're all gathered, but ultimately, we all benefit. It's a win-win for the individual, for the system, and for the economy, because we do boost our productivity as a result. And really, that is the business case, for tackling health inequalities told by the people themselves.
Thank you so much. I mean, absolutely fascinating. And I think it's so important, isn't it, to be matching up the people with the graphs and not just talking about the graphs, because it's so easy to lose sight of what this is actually about. I'm going to go straight to the floor and see if anyone has any questions for Bola. I know we're early in the session and sometimes people take a little while to warm up, but does anyone have any questions? Yes, we've got a question down here. Just the woman there. Perfect. If you could say who you are and where you're from.
Hi. Hello, I'm Hazel Cheeseman, Deputy Chief Executive at Action on Smoking and Health. Great to see that graph, Bola, on the targeted lung health checks and the improving ability to identify people. But the support for smokers to quit smoking is not a funded, embedded part of that model. And it means that we are identifying people who we could be helping to stop smoking and avoid the cardiovascular disease, etc., etc. And we're not necessarily doing that. And I see today that the government have said that they're not going to follow the Hewitt recommendation around sort of carving out some money on the prevention, to fund the prevention work that we need to do. So I guess my question is, if we're not going to really fund the investment in prevention services, your optimism around health inequalities and reducing the gaps in life expectancy for people with serious mental illness, etc., how are we going to get there if we don't invest in prevention services?
Hazel, it's really good to see you. And many people will have heard me talk about circles of influence and circles of concern. Let me focus on our circle of influence. And I'm sure Rob and Owen will talk more about that. What we do have is that every integrated care board does have a health inequalities adjustment in their allocation baseline. That we all have. And we've seen some excellent work across the country, whether that is in West Yorkshire, which is where Rob is leading, and how they're intentionally investing that health inequalities adjustment to drive improvements in health equity across the board, including things like smoking cessation. So that's where I would want us to steer the conversation, is about the courageous leadership that asks the question of how we use the investment that is already there for the purpose for which it is intended, for the groups of people for whom it is intended. I think that would be my answer. And to say that, the targeted lung health check program does have identification of smoking and signposting to support as an integral part of it. And I think that's powerful. But it's about us then meeting the program halfway by using that adjustment to make the services available as well.
Thank you so much. And there's a question come in on Slido, which is a really big question, and maybe it's something that we can start to answer throughout, not just by you, Bola, but by all of our speakers, which is, how does tackling the climate crisis align with tackling health inequalities? So, really big and important issue.
It's a really big and important issue, and I would signpost people to read the Chief Medical Officer's annual report of 2022. There's a section in there on health inequalities and air pollution. And it shows us that the people from our poorest communities have the highest exposure to air pollution. Therefore, they bear the biggest brunt of the health costs of that exposure. But actually, more importantly, it begins to talk about, and what are the tangible actions that we can take? focusing on the NHS in particular. So talking about the gases that we use for our anesthesia, and Dr. Nick Watts, who is our Chief Sustainability Officer, and his team are leading fantastic work in that regard. What we can do with our own fleet of vehicles. Many of you would have seen the electric ambulances, for example. So there are things, again, circles of influence versus circles of concern. A whole raft of interventions, how we travel, as NHS staff and colleagues. All of those contributions we can make to the air pollution question, which is one of the manifestations of climate impact on health inequalities. There is a circle of influence there as well.
Thank you so much, Bola. And I'm going to move on now to bring Rob in, and I'm going to introduce him properly. So, Professor, as it says on his badge, Rob Webster, Chief Executive of West Yorkshire Integrated Care Board. And Rob's going to start to talk about system incentives and objectives and how we start to overcome some of those misalignments. And I think, I'm not sure if this is a misalignment or an obstacle, but it's really interesting on Slido, barriers that people have cited quite a lot around funding here. And I just think that we do need to touch on some of that. So what's the obstacle you face? Retaining funding when our system is in deficit for these issues. And we said at the beginning, this isn't a nice to have. So perhaps we can tackle some of that in here as well. But over to you, Rob.
Hello, everybody. My name's Rob, and it's an honorary professorship, so I'm not really a proper professor. So I wouldn't start there. I think it's important for us to start to think about what's in view here. Often I feel like the debate that we have and the actions that we take are based on what's in front of us. And like a picture that's made up of millions of dots, what we see is the dots in front of us. What we need to do is move back and see what the big picture actually is. And if we don't do both, focus that every dot's important in making that picture, but we have to see the big picture. And integrated care systems, as systems made up of partners, the NHS, local government, the third sector and communities, look at that big picture. They're designed to tackle health inequalities, manage unwarranted variations in care, use resources wisely, and get the biggest impact in terms of social improvement and economic impact possible. That's in statute now, but that's the job that ICSs are being given. They do that through a partnership board which governs a strategy. That strategy is delivered by an integrated care board as an organisation with its partners, those local authorities, those NHS trusts, those GPs, those third sector bodies and communities. And they do that in the places where people live and with provider collaboratives. That's our job. Everyone on this panel has to do that, whether it's a provider chief exec, an ICS chief exec, someone from NHS England. That's our job. That's your job in the audience. We need to see that picture. We need to see those populations, and we need to really understand what's happening at the moment. So you heard from Bola about those shocking but not surprising statistics about the impact of the pandemic. We know that disproportionately poorer people had a rougher time. We know 61% of people died in the pandemic in the first year who had a disability. So every time you heard on the news somebody saying almost as if it was okay, don't worry too much about dying because it's people with an underlying condition who are at risk. We were excusing complicitly the idea that people were worthless. So what we've got to do is see the big picture, and what we've got to ask ourselves is, are we developing a system that's going to allow us to tackle the health inequalities that are behind much of the challenges that we face today? Because if you look at elective recovery, the state of mental health beds, whether ambulances can turn up on time, whether you can access a GP, a dentist or a pharmacist to get your medication on time, these things are all driven by where you live, whether you've got a disability, what your ethnicity is, how poor you are. That's a fact. We all know it. It's not a surprise. And what we should be doing is creating a system that's going to allow us to do something about it. Now, ICSs have been around in some form for 6-7 years, and some people that I've learned from across the country are doing some really good work, and I think we're doing some good work on this. Once you start to look at what the public wants, you can get into a really good discussion about this. So I hear often, sometimes from local government partners, sometimes from third sector partners, sometimes from politicians, that it's typical of the NHS to go back to obsessing about waiting times, access to general practice, E&E performance. At the same time, Healthwatch in West Yorkshire did a big piece of work with local communities that said, what do you want from us? What they said was, I want to be able to go to the doctors and get an appointment. I want my operation on time. If I ring the ambulance, I want it to turn up. I want a carer that's going to look after my mum, my sister, my son, alongside me. I want to make sure I can access a dentist. It's the same stuff. It's the same stuff. But we spend our time othering people instead of getting behind a common objective and a common narrative. Now, once you get behind what's going on in our systems, our organisations, and Owen will talk about this in a minute, what you can see is that if you look at the big picture, that what lies behind performance and the issues that affect us is inequality, driven by deprivation and ethnicity. Now, you're in Greater Manchester today, and Greater Manchester is a bit like West Yorkshire. West Yorkshire, you know, we speak in averages. 20% of people live in the lowest quintile of deprivation. 33% in West Yorkshire. 22% of people live in the bottom decile. 28% are kids. It's not the average, it's different. We've got to focus on that. Once we start to focus on that, we say, okay, what's happening to them then? If we've got a system that's made up of the system provider collaboratives in places thinking about the issues that the public and our regulator want us to look at, let's take ambulances. Ambulance response times have been pretty horrendous, is the only word I would use, over the winter. And we've all struggled with that. We did a bit of work started in mid-Yorkshire. One of the trust coups said, what's going on with the people who turn up in ambulances at Pinderfields Hospital? And doing a bit of work between the partners in the place with the ambulance service and the hospital, what they found was that 60% of people who were conveyed in ambulance came from the lowest 2 deciles of deprivation, 60%. And of those, 80% needed just a one-off intervention. So they were being brought in an ambulance to a hospital where they just needed one thing doing. Mm-hmm. Why weren't they using the pharmacy, the GP, or anything else? So we did some work with the Academic Health Science Network and said, well, who is it that's in those ambulances? Well, you might think, well, it's going to be lonely, frail, older people. It's not. It's women aged 20 to 35 who've got mental distress. And it's women with cold babies who are worried about their health. So how do we solve ambulance response times? It's not by shouting at ambulance services. It's by looking at what are the housing conditions of people in those communities. What is it that's causing them to have to ring an ambulance to be conveyed somewhere rather than get the bus? What's going on in those communities? So it's the same story once you start to look at mental illness. Again, one of our providers has been looking at, if you look at ethnicity, what proportion of people who are referred into mental health services come from different populations, and how does that compare with the population in the place? In every single place that they operate, if say 20% of the population comes from the global majority, only 10% of people who are referred into mental health services are from the global majority. About half of the population you might expect, half of the rate. If you look at who's in an inpatient bed, it's representative. What's going on? Why aren't people accessing primary mental health services in the community when they're needed? What is it about that? Because when you look at the waiting times for those populations, actually people get seen really quickly. So is it because they're sicker? Because we've let them get sicker because they weren't referred into treatment. Now, these issues, looking at these sorts of issues, are part of what we need to do. So in West Yorkshire, rather than just say, look, there's a problem here, let's admire it. Mm-hmm. We have to look at, have we got the capacity, the capability, and the tools to do something about it? So we have a Health Inequalities Academy, we have a Health Equity Fellowship, we have a Health Improvement Prevention Pathway tool. What that does, it says, okay, let's take people with a serious mental illness. If we stratify that population, what is it that's going to be affecting them in terms of tertiary prevention? So if you've got a serious mental illness, you're more likely to be vulnerably housed. You're more likely to lose your house if you go into hospital. You're more likely to go into hospital. What are we going to do to make that difference to those people? Okay, let's take secondary prevention, which is about targeting the existing resources that you've got through your GPs, pharmacies, everything else at the right thing. What is it about people with serious mental illness that is going to improve? Well, let's take health checks. Health checks people with serious mental illness in Colindale, 10%. 10%. It's up to 56% now. Why is it at 56%? Because we've done some insight work with people with lived experience to redesign the communication, the type of letter that you get, the way that the clinics work, who's in the clinic, and how it feels for you, because that will improve the likelihood that you will get your overshadowed diseases found and your treatments sorted. And then tertiary prevention, there's the same kind of approach to interventions. Now, we've got to have these kind of systemic and systematic approaches to addressing issues. If you can do this, then you start to stop seeing children in acute physical beds. You start to make sure that people aren't seen in mental health beds hundreds of miles away. You start to deal with a problem that you've really got, which is described in a different way as a target. Now, I could keep going on, and maybe we'll come back to some of the other examples, but we need a system which recognises that's the world we're in now. It feels to me like we're in a liminal space between the past and the future. We're coming out of the pandemic to live with COVID. We're in a new fiscal environment. We're in an environment where our staff need some hope and we need a better future. So we need to create it together using these arrangements. And we need to use the money that we've got on the right stuff. So if the money's a barrier, you've got to ask yourself in trusts, what are you spending your money on? And who? And why? And if you're in a system, how do we use that money better together? Because we'll still need to have people in beds, but they should be the right ones. We'll still need to see GPs seeing people, but they should be seeing the right people. We still need to get people supporting people to stay well because they can. And that requires us to do much, much, much better at aligning regulation, financial flows, oversight, and it requires us to back systems to deliver what they're statutorily required to do. And the last reflection I would give is that, when things get really tough in the past, because let's remember the fiscal environment's not been good for a long time. In the past, I've worked with people who said, it's okay, I'm delivering my statutory duties. That's not good. That's not where you should be. You should be trying to delight people. You should be trying to create an ambitious future. But if you're one of those people who believe you just have to deliver your statutory duties, well, make tackling health inequalities delivering your statutory duties then.
Thank you, Rob. And I think I'm going to move us straight on to Owen, and then we will open up for Q&A. And so before you start, Owen, I will just introduce you. So got Dr. Owen Williams. There's a theme here, professors and doctors on this.
You're not going to say I'm a real doctor, are you?
He's a real doctor. He's got the qualifications and everything.
Yeah, he's got qualification and everything. So Dr. Owen Williams, who's Chief Executive of the Northern Care Alliance NHS Foundation Trust, and you're going to talk about some of the improvements you've made in your trust. Over to you.
Thank you. And you two did run over, by the way. I'll make a note of that a little bit later. But I do want to say something.
3 wrongs do not make a right, Owen.
I do want to say something, because the colleagues to my left, actually, including Saffron, have all played a quite important role. And the thing that they've got in common is that they're leaders. They've shown leadership when it's been easier, perhaps, to take a back seat and let somebody else do it. So I think that's an important thing that I'll say. I'm going to try and speed date you all so we can get to some questions. And one of the things, if you ever hear me talk about health inequalities, there was an acronym that we developed as a part of some of the work around the pandemic, which was about, when you see health inequalities, be sure. If you want to tackle it, be sure. And what the SURE stands for is a simple acronym. The S stands for see it, U stands for understand it, R for respond to it, and E, evaluate it. And the next 2 or 3 slides, there's only 2 or 3 slides, I'm going to be focusing on the see it and the kind of flirting a little bit with the understand it bit. And I'm quite blessed because right in front of me I can see the chair of our trust. I can see a non-executive director, chair of our quality and performance committee, and there is not a conversation that I have with them that does not feature health inequalities, which starts to get you an understanding about the theme. But what's really, really important alongside that is, given that particularly if I take our organisation, the Northern Care Alliance, you know, we're an organisation that has got thousands of doctors, nurses, therapists, you know, porters, cleaners, you name it, social care workers, right across the piece. But there is something about how you get people into a conversation. And this little chart here starts to just give an idea about how we try and get our clinical colleagues, and I'm using that in its multidisciplinary sense, inclusive of community, not just hospital mentality. It's how you get into a conversation. So one of the big conversations that we have, particularly if you are a person who works in urgent and emergency care, is there is this ongoing anxiety that the focus on elective care or planned care is taking away a focus around urgent and emergency care. So one of the conversations we try to have, and it's a starting conversation, I don't want to give any false impressions, but it's to give you a flavour about how we're trying to get the conversation going, is to just try and map some of these data sets together and to get people to just think about, is there a relationship potentially with the patient who is on the elective waiting list, and also the potential for that same patient to require one or more urgent and emergency care visits. Now, what this little black dotted line shows you is it shows you that, and this is a data set that relates to data from January 2022. So it's that cohort of data. So anybody from NHS England who's saying, has he still got 104-week waiters? Have mercy. But what this chart says, if you just understand the flow, is that there is a greater probability that if you are an elective patient and you have been waiting for 104 weeks, for example, there's a kind of 1 in sort of, or a 10% chance or probability that you will have visited urgent and emergency care within 1 or more times. Now, there's a real health warning here, and it talks to a little bit that I think what Bola and Rob have talked about. It can be so seductive to get entrapped into the what I call single number. Okay, so this line, you could argue, represents a single number. But this line and this chart, and I want you to remember the dotted line, tells a slightly different story, because all it's doing is looking at the same data, but it is splitting it out into quintiles. Or if you're into deciles, it's deciles 1 and 2 to make quintile 1, deciles 3 and 4 to make quintile 2. And apologies if you're colourblind, but just to try and get a point across to you, that the minute you start to look at things through a broader lens than just the dotted line, the aggregate number, the bottom right-hand corner, you start to see a different picture. You start to see that our most deprived communities, their probability and their risk when they're sat on an elective waiting list is greater than somebody who is in a least deprived or a lesser deprived communities. Now, there will be somebody out there saying, well, I know that. Well, my next question to you is, well, what are you doing about it? Okay? And when next, because we aren't going to be around forever, because I'm also very keen to see where the next generation of leaders are going to be in terms of taking this forward. And just one final dimension that I'll just talk about is, so we're the Northern Care Alliance, and to go to the question that was asked earlier about, resourcing and prioritising resourcing, our organisation is a £1.6 billion organisation sat within a Greater Manchester construct that has £6.5 billion that is targeted towards health and social care in some way, shape or form. there is a little bit of me that just says, gosh, if we can't do something with that, well, you know, we might all as well go home. But if I talk particularly here, this is about workforce, and this is where I try and blend the conversation so that we're not just talking about patients per se, that actually we start to look a little bit about our workforce. And we all know that in terms of equality, diversity, inclusion, for all sorts of reasons, there is pressure around equality, diversity, inclusion. There are some forums where you can't even have the conversation anymore. Again, I know I'm on a table or in an arena where that's never going to happen with the colleagues I'm sat with, and I'm hoping it's never going to happen with you. And here's an example of where I need you to start interrogating your own information. Whether you're a part of a voluntary and community social enterprise organisation, you're a private sector organisation, or whether you work in the public sector or you work for the NHS. And all this chart shows is it shows indices of multiple deprivation in the horizontal axis, and it shows indices multiple deprivation 1, okay, which as I'm looking at the chart is to my left, right through to indices of multiple deprivation 10, okay. But what it does is it splits the 20,000 colleagues who work for the Northern Care Alliance, it just splits them by ethnicity, of black, Asian, minority, ethnic, and white. Okay, and guess what? What do you start to see? Well, I'm not even going to answer that question for you, okay? And I'm not going to try and explain what indices of multiple deprivation are, because I kind of expect now everybody in the audience, thanks to Core 20+5, etc., work with Rob, I expect people to know. And if you do know, the question to yourself is, what does that data say to you? My final vignette on that is, that data to me shows a massive opportunity. And perhaps an opportunity to think about, if we've got 20,000 colleagues, if you are black, Asian, minority, ethnic, and you are more likely to be in indices of deprivation 1 and 2, I can take the glass half empty on that, but I can also ask the question of, when people talk about prevention and upstream, imagine if we start seeing our workforce as more than workforce. Let's start seeing them as people. Let's start seeing them as the roles that they play in their communities, the voluntary they do, the ambassadorial roles that many of these colleagues will have in our communities. And then you start to see the opportunity. And at that point, I'll shut up.
Thank you so much. That was really, really fascinating. Rob, you want to come in?
I just add one other comment about staffing. So we've just done a big piece of work in North East Yorkshire, and was supported by NHS England, but all of the ICSs together, about attendance. So as Owen's described, our staff are our communities. I've just described to you that we've got sicker communities and poorer communities in the north of England. What that means in terms of attendance is every day we have 1% higher sickness rate than the England average. It's 1,000 less staff at work than you'd expect. In West Yorkshire alone, 1,000 less staff at work because they're sicker. If we were able to turn that curve a little bit, imagine how good we'd be if we just got to a bit better in terms of people being able to come to work. It would make a huge difference to them. It would make a huge difference to us.
Absolutely. Thank you. Really important point. Okay, it's over to you now, audience and Slido people. So we're going to ask for some questions from you. So can I ask you to put your hand up if you've got any questions for the panel? Oh, they're coming in thick and fast. Can't see very well. I'm going to go to the gentleman there first, that's right, and then I'll come to the lady at the front here, and then we'll go to the other two in a moment. Thank you.
I'm really interested.
Can you say who you are and where you're from?
Yeah, Prince Obike, NHS Frimley.
Okay.
I just hear quite a great deal about poorer communities having, kind of poorer outcomes. But I'm really interested in what can we actually do anything about it? Because sometimes we recognize some people just live, within the environment they live in, the poorer community, etc. But sometimes there are certain circumstances that try whatever we can, there's nothing we can do about it. So I would like to know from the panel just exactly what you have done, or what the NHS has done to try and address some of those poverty circumstances that is contributing to poorer outcome. And more importantly, clearly, what we have done with our partners to make it happen. You know, we talk about the NHS being able to invest in the economic growth of the local community, but it would be really interesting to see, yes, we identify the poverty, but how have we worked with our local authority and partners and local businesses to change the circumstances within which people find themselves?
Thank you. Really good question. And go to the lady at the front as well, and then we'll take the two together.
Hello, thank you so much for a really good conversation. I'm Julia Darko. I'm a GP trainee, but also clinical fellow at NHS England, and a really big interest in health inequalities. So my question was, because I don't hear this kind of addressed enough, what can we do to deprivatise the elements of the NHS that have been increasingly privatised over the last decade? So I'm thinking specifically of, for example, prescription fees, optometry, dentistry, those areas that link into what Bola specifically talked about, long-term conditions affecting the more deprived populations earlier and for longer, and seem to me as obvious areas that should be tackled in terms of improving that equity of access.
Thank you. Thank you for that question. Okay, so over to you, panel. We've got one on what are we actually doing in communities to tackle poverty? So I think a really good and fundamental question. And then also, if someone wants to tackle the privatisation question, that would be great. But I'm going to go to Rob first, who indicated he would answer on the deprivation one, and then we'll go across the panel.
So for a place like West Yorkshire, first thing we realise is that you've got to reframe how you think about the 5.2 billion quid that we spend, and really embrace that idea that we can deliver the biggest economic and social return with that money if we think about it differently. It's an investment, not a cost. You know, everyone talks about the NHS and social care being a cost. It's an investment. It's 100,000 jobs. We've got big capital developments coming along and so on. So if you do that, you then talk to the local enterprise partnership and the mayor about, well, what's the industrial strategy and how do we get inclusive growth? And that's what we've done. So our industrial strategy and our ICB strategy were signed off on the same day by the same people. Alongside that, then in terms of what can you do about jobs? Well, there are some jobs that we've got and some things that we create that can make a difference in the poorest communities. Red Kite View is a brand new CAMS facility in Armley in Leeds, which is one of the poorest parts of the city. We decided collectively as chief executives when we first started as an STP-ICS that that would be a priority for us, because we had 8 beds for kids in West Yorkshire. We had 22 kids in beds, so most of them were out of area. When we created that, though, we said it should be a facility that's staffed by local people, built with local firms, and we should go out of our way to make sure that's the case. So the way that we recruited, inducted, and kept the staff at Red Kite View meant that we've got people who work there who never had a job. And what we found after a year was that they're more likely to stay. So the benefit for us and the benefit for them is huge. And changing our outlook on this, we can put into the social return elements of contracts. It's the same in Owen's old trust in Huddersfield with their new A&E, where the apprenticeships that are in there, the local firms that are being used for everything from the scaffolding and the barriers round to the structure of the building. So you can do the stuff with the mayors and the local enterprise partnerships. You can do things about the way that you spend money, and then you've got to think about if you and your partners can intervene during the cost of living crisis, then do so. So our directors of public health, working with councils and with organisations, have put together a whole suite of things that can just help people stay warm, stay well during what is a really, really difficult period.
I'm going to go to Bola now. Thank you, Rob.
Thank you, Rob. It's always really important to give those specific examples.
Yeah.
So just let me take you back to the film at the start, because I think those individuals told us how. So the last person on the film was from Birmingham, and that's Birmingham Hospitals, who developed this homelessness project for young people, where they housed homeless young people, trained them to be able to do some work, employed them, so they're employed working in the trust, they're no longer homeless, and they call it a no-benefit scheme, which means they're not having to call upon the welfare state either. So that's one great example. Elliot, the young man in the dispensary with learning disability, it's a collaboration between the NHS and the sixth form colleges, whereby they offer people with learning disability a 12-month placement in the hospital, acquiring really good skills, but actually doing great work, as you saw Elliot doing, as a route out of unemployment, which of course is one of the social determinants driving health inequalities. Clacton-on-Sea, again, the NHS, Health Education England, the Ports Authorities there, the sixth form colleges, again, recruiting people with learning disability, training them to be peer researchers. And by doing that, it means that they've acquired a set of skills that they can actually now use to go and get gainful employment. Community diagnostic centers in Somerset, they used the fact that within the commissioning framework, we said it should have health inequalities as a priority. So they placed their community diagnostic center within some of their most deprived areas, were able to train a whole range of people who were out of work, many of who then went to secure work, not just in the community diagnostic center itself, but some of them not even in the NHS, but in other industries around the area. So I think it's about that thinking carefully about the population. You know, that core 20 plus 5 ethos, who are your core 20 plus? And I'll call out your Frimley system. I've been in Frimley twice. I was there again 2 weeks ago, and the fantastic multi-generational household pilot that Dr. Priya Kumar, sitting just over there, is running, which actually took your COVID pandemic data of households that are really struggling, and now there is a service to actually support them in terms of their health, and you can see how that will translate into economic benefits. So I think we're not short of examples. It's the courageous leadership to not reinvent the wheel. Yeah. But look over the fence, what are they doing over there, and how are we going to do it over here?
Thank you, Bola. Owen, you've drawn the short straw, and you're going to answer the question around access to optometry, access to dentistry, and, you know, are we seeing this increasing privatisation?
You know, it's a really difficult. So I get the prism, and I get the concern, but you know, somebody, as a person answering this question, I've worked in the private sector. I've worked as a local government chief exec, and now here I am working in. And in my transition from local government to the NHS, one of the biggest learning points for me was I never knew how many, for example, of our clinical colleagues worked in the private sector. I didn't know that. And so there's a bit for me where, over the years, I've kind of tried to move away from getting diverted into that discussion, even though I know it's really important for lots of people potentially in this room. But for me, I'm in the place of what is actually making a difference? What's the outcomes that we're really talking about, and what's making a difference? And yes, sure, we need to have a thought process about the how, and if there is better utilisation of resources in one part of the world versus another, then great. But let's not kid ourselves. You know, the NHS, general practice, and several other areas I can think of, for example, in primary care, beyond the general practice, have been involved as independent sector providers or private sector organisations. So there's a thing for me that says, yeah, we can really get sucked into that discussion, and as I say, maybe in a political paradigm it's a very important discussion to have, but all the time I just keep coming back to a simple thing that me and him have been saying to each other for donkey's years, which is it legal, and will it make a difference? And there's just something about, I get the sensitivity of your question, and I don't want to diminish the importance of that conversation that's important to you about how things are provided, and does that mean that resources are potentially getting drained away from the public sector into private sector, and is that the right thing to do? But I guess I'm just in the space of that patient and colleague well-being, and I kind of will do what I need to do to influence to get the change there.
Thank you, Owen. I'm just going to come to Bola. She's indicated she wants to come in.
Just on the point around, you know, and I'll keep harking back to circles of influence, building on Owen's point there. Prescription charges for people living with long-term conditions. Here is an ask of the audience. So we commissioned NHS Business Services Authority a few months ago to run the data on existing prescription exemption schemes and who is actually accessing those schemes. So maternity was one of them. And as I've said in many forums, looking at the data, it's not our most disadvantaged women who are picking up the prescription exemption for maternity. It's the well-heeled, sharp-elbowed, middle-class women like Bola who are picking up that exemption certificate. So the circle of influence is, can we please go and have the conversation in your local provider trusts, in your ICBs, in your ICS, with our community pharmacy colleagues, to be the voices to remind people that there are existing prescription exemption schemes, but it's about who is making the most of that service, and how do we make sure that it is the core 20 plus for whom it's meant that are using it.
Thank you. I want to fit a couple more questions in. It says we've got 4 minutes left. Before we do that, those of you who are using Slido, can you use Slido right now to put in what's the one word action or insight that you will take away from today? So we want you to use Slido to tell us that. We will come back to that in 3.5 minutes time now. We had some other questions. So we've got a gentleman there, and then I'm going to go for one more in the front, and then that will be it. And can we make them really pithy, short questions?
Thank you very much, Bola, Rob, and Ewan. This was really about talking.
Can you say who you are?
Yeah, sorry. My name's Chand Nagpal. I'm a GP. I've been a GP for 30 years. I'm representing the NHS Race and Health Observatory. I was previously BMA Council Chair. I want to just talk about general practice. We've heard a lot about planned care, emergency care, elective waits. But, you know, there is so much inequity I see on a day-to-day basis that isn't, I believe, measured or therefore not tackled. If you talk about prescription exemption, for example, the push, for example, that NHS England itself has done to tell patients to buy medication over the counter is actually disadvantaging the poorest, as an example, directly creating inequalities. If I look at consultation lengths, evidence that social class 1 patients actually spend longer with their GP than social class 5 and have the least health needs. If you look at language barriers, there's nothing in my consultation that gives me extra time for those patients. Learning disability, again, the same consultation time. And if I actually look at the pressure for increased access, and we're being performance managed on access, actually I would argue there's an inverse relationship, and that the greater the access, the more inequality, because the patients who really need it won't be given the time. No one's measuring that. Late presentation for cancer, for black patients for cancer, again is around those issues. The uptake of the NHS app amongst black patients is much lower than those white populations, but no one's really doing anything about it. And I've heard so many examples of good practice, but not with regards to general practice, specifically asylum seekers, refugee patients. Every day in my practice, they're being shortchanged. All I'm pleading for is that we really start to talk more about that level of first contact experience, and not just about hospital waits, which are very important, don't get me wrong. But please, can we start measuring this and performance managing the NHS to do better in primary care? Thank you.
Thank you. Okay. I'm going to go to which one of our panel wants to answer that one?
I'd like to talk about
or comment on that, and then Bola, very quickly, because we're running short of time.
It's not often I would praise Sky News, but there was a little 2-minute vignette they did around general practice and its relationship with health inequalities, and it was talking about you know, the shortage of GPs generally, and it was then juxtaposing that against deprivation. All I would say is we know for a fact that when you think about a GP practice, if it is in an area of least deprivation, it's likely to get greater funding than a GP practice that is in an area of more deprivation. This is the one where I come back to the point, and it goes to the smoking cessation point. I'm not looking to other people, other than the system partners that I work with, to try and address that. It's wrong of me, and would be wrong of me, to say, just describe that problem and then say it's for someone else to fix. And I think there's something about us taking the leadership role. You know, we can influence things, we can make a difference, it's working with our communities, being led by our communities to make a difference in some of this.
Thank you. And I'm going to bring Bola and Robin, but I'm going to ask you to be painfully quick,
Sure.
because we are running out of time.
So, Chand, great to see you, and thank you for that challenge. And I couldn't agree more with Owen about that local leadership and responsibility. The last example I gave about the multi-generational household project, it's a general practice project, but it was the ICB that decided that actually these are the sorts of households that do seem to have poorer outcomes. Let's frame a service around it, and that's what they're doing. And there are lots of examples like that across the country, the deep end GPs, for example. But you have made some really important challenges. But what I would be pleading is to say, the health inequalities adjustment I mentioned earlier, the most significant proportion of it is primary care. And therefore, what is the conversation we can have as an ICB around that, and how we might deploy to start addressing some of the really key points that you've just raised there. But it's that local opportunity to make a difference with what we already have, but not in any way diminishing the need for us to have a national focus on it as well.
Thank you, Bola. And just before we come to Rob, can I ask our AV colleagues to reveal the word cloud that should come up from your one-word responses from that? And I'm just going to finish off with Rob. What was your response to Chand there?
So thanks, Chand, for raising that. So, well, firstly, general practice has been fundamentally brilliant over the last 3 years in tackling the pandemic, responding to changes in practice, doing more work than it did prior to the pandemic, and more of it face-to-face, despite what everyone says. And the majority of people are satisfied with the service that they get, but a large minority aren't. So we have to address that, and there are ways we can do that. But in doing that, I think we have to speak to your point, Chand. So one of the things we've been doing in West Yorkshire is working with South Bank University on something called universal healthcare. How do we redesign primary care so that we address the points that you raise and get to maybe challenge the inverse care law for a change?
Yeah.
Why don't we get to the point where people who need the most care get the most care and not the least? That requires us to think differently, but collectively, if the fuller review is about segmenting the population, thinking about episodic care, ongoing care and prevention, we should be using that as a vehicle for describing what you're saying. And the very last thing I'll say, because you mentioned refugees and asylum seekers, is we're the first system of sanctuary in the country as an ICB, and everybody in this room should be thinking about how do their organisations become organisations of sanctuary in what is a toxic environment for refugees and asylum seekers as an act of leadership.
Thank you. We have overrun, for which I'm sorry. That's entirely on me and my bad. But I think there were so many good questions and great answers. I could listen to this panel for a lot longer, and I'm sorry we have to bring it to the close. I think that it was really fascinating to hear your different perspectives, and I thought it was really interesting that, Bola, you were talking about let's see the person, and Rob, you came in with let's see the big picture, and then Owen, you came in with let's see the workforce. And I think it just speaks to how many dimensions there are and the different perspectives we can bring to it. And I'm sure you also all see those other perspectives, but I think it's so important that we remember this isn't a single issue. This isn't something that you tackle just by focusing on one thing. And I think probably the other thing you said, Owen, about there isn't a single number. Don't look at that single number, I think is really important. So can we thank the panel in the usual way, because they were brilliant. Thank you.